So at the outset, I would like to invite our expert panel for the Leadership Development Program. I request Dr. Kalpana, Madam, she's already here, and Dr. Deepak Megur is on his way. And then we have our moderators, none other than Dr. CR, Dr. Chitra Ramurthy, Dr. Tamil, and Dr. Satyajit. So without wasting much time, I think it's now the time to hear from the great luminaries, the legends in ophthalmology. I request Dr. RDR sir, whom he's, I think, fondly called as Dr. R.D. Ravindran sir, to please speak on the outpatient clinical setup and the specific planning.
Good morning. At the outset, I'd like to thank. Can you increase the volume? Yeah. Good morning. At the outset, I'd like to thank Dr. Chitra and the ARC team for this opportunity to share my ideas on how do you set up an outpatient department. Dr. Chitra asked for some specific planning that will go into setting up an outpatient clinic. So there are two things very important when we set up any clinical services. One, how do we build the trust in our clinical services is very important. So for developing the community faith and building trust in our services happen only if we have empathy and compassion in our approach, in the way we manage the patients, if there is transparency in our systems, if we are going to treat everybody equally, and very, very important is also the clinical quality. So without that, we will not be able to sustain the trust, neither will be able to grow. If you have to grow, I think these are all the fundamental attitudes with which the organization has to work. But again, ophthalmology is a high volume specialty. So the operational efficiency is also equally important. On one side, while we have to be empathetic and compassionate, maintain quality, the other hand, we also have to ensure that the operational efficiency, so that the certain number of patients are processed and counseled, either they get their services, medicine, glasses, and leave. And this efficiency and the quality, when I say quality, it also means both the clinical and the service quality has to happen at every patient interaction. And ophthalmology is a very complex. We have at least about 10 or 12 interactions. In some places, these all happen at separate stations. In some places, a single or two or three people will provide these services. And coming to the planning part, first is we need to look at how much infrastructure we are going to have. That has to be based on the projected OPD. So when you are, for example, if you are building a new facility, it should be based on the volume you will have in the next 3 to 5 years. Usually, typically, whatever you see the first or second year, by the fifth year, it will become either double or more than double. The second, it's also based on the services you want to provide in the thing. If it's going to be single practice or multiple players with the different specialties. I don't know if you, for example, if you're going to have a general outpatient clinic without much other specialties, probably about 2,500 square feet space for 100 to 125 patients you're going to see is what is needed. This is for your reception, medical records, refraction, optical, other amenities. It's all important. And it's also ideal to know if you are able to cluster your optical reception cafe in that one place along with the main waiting area. So this is briefly on the planning. The second is, if you are planning your facility, it's always better to provide all these facilities in one single area, so that you have to minimize the movement of the patients. As ophthalmology, there are many things. You have to check the vision, refraction, intraocular pressure, blood pressure, doctor's examination, dilatation, maybe other investigations. If it is all in one particular area, and then the movement of the patient becomes less. Otherwise, you need people who have to be taken to those places, which again increases the number of personnel. The third important thing is, how do you standardize for efficiency? Okay, one is we need to know how to streamline the workflow. Then we also should understand how do we delegate the workforce. Then identifying persons responsible for each of their tasks, and also how do we define, I'm going to talk about each one of that. One is, it's also about important that as you start your practice, you plan for setting up a clinical OPD, standardizing the case record becomes very, very important. Not only case sheets, now today we also need to have, like a counseling card. It's better to, I'll come to this later. Then you have this biometry, drug prescription, your consent from all of that, as you start. It's always better that you standardize it. You have them all in place before you start it. And again, you also define, so that every staff understand how the patient will move from station 1 to station B, which is station 1, which is station 2, where will they be seen. So if you are able to define that pathway, then there is also a better understanding in the team, and they will also be much more productive. So defining this, I've just put it for a cataract patient, even for a general outpatient who comes into the hospital, how you are going to plan that pathway is very, very important. And again, delegation, anything, it's a skill-based repetitive work. I think as doctors, we should not do it. You should delegate it to a paramedical person who can be trained. Some of the things probably people must have some kind of a basic qualification. Otherwise, we should be able to train anyone, and it can be done. And typically, if one doctor has to be really productive, if you've got a good practice, if you have to be productive, you need at least 4 or 5 people to support you in the outpatient department. That's how you also plan your manpower. And again, and as you delegate, you also have to define what do you expect from that person. For example, if you say this person is going to do counseling, they have to be very clear about the pre-operative preparation, the consent form, post-operative instruction, in addition to what are the package costs, making sure that the patient is fit for surgery. And if you have an inpatient thing, what is the room booking, or if it's a daycare, what time they're supposed to come. All of that has to be defined. So not only define that, but you also have a form. That's what I showed you. You have a form that will capture all this information to make sure that it's like a checklist. So you're defining what this person will do all of this. Even when you define what the refractionist will do, make sure that all that has to be done is captured in that refraction sheet. So identifying a person is important. Equally important is identifying or structuring what they will do is also very, very important. So in that way, you'll be able to assess their outcome and also assess that person's work quantitatively and qualitatively. The other thing that will help in efficiency is how do you emphasize on clinical diagnosis and minimize the tests. And again, if you are able to eliminate waiting list, either for investigation, for surgery, you will become a lot more efficient. By giving an appointment, asking the patient to come some other time, you have to know, for example, a patient comes today and you ask them to come for OCT some other day, you have to understand when they come, you have to register them. And you have to find a place for them to stay. And some of these processes also may have to be repeated there, so that the whole thing becomes very inefficient. So we have seen in a place where there was an 800 OPD, only 200 were new patients, the rest 600 were review patients. Even for refraction, any investigation, they had to come. All these could have been avoided. So then you'll create also room or space for other people to come in. Other equally important is the resources. If you don't have a good team to maintain, not only to examine patients, but also at least a person to take care of the instruments, or the people who are there aware of how to take care of the minor repair, you are going to lose on that. So the whole efficiency part will be lost. Either having an in-house maintenance team or somebody who can come and quickly repair it is also very, very important. So that's for the standard. But for the effectiveness, to make sure that they get good treatment, you need guidelines for the clinical areas, not only for just advising surgery, even a post-operative follow-up guideline. If you have a system like this, like a post-operatively, what the counselor is supposed to do, if it's all defined, and and you also get it signed by the patient, give them a copy, and you retain a copy, then the whole protocol is also adhered to. And again, ophthalmology, we can tend to make mistakes. So make sure that you have a clearly well-defined safety goals for each of the persons. So what they are supposed to do. Now, what kind of things they'll make sure that that there are no errors will happen in the work. Otherwise, if that person does a wrong refraction, your optometrist, you are going to end up prescribing that glass may probably cost 30 or 40,000 rupees. So that will be a burden on your practice to make sure that no mistake happens is also equally important. The other important thing is very, very important. How do you set service standard? Now, for example, a patient has come to my OP. This patient is going to leave within 1 hour, or his patient is going to leave within 90 minutes. You have to fix that. Based on that time, then you also fix what is the manpower you need to accomplish that. And that should become the standard manpower. And as your OPD grows, or you based on the projected OPD, you have to make sure that you have that manpower, so that only when you have the adequate manpower you'll be able to accomplish your service standards. So, and again, making sure that this manpower, not only having adequate manpower, but making sure that they really understand their work. And whether, for example, this is like a vision. If it's a vision, it means there are 5 or 6 steps. One is they have to identify the correct patient. They have to take a brief history. They do a torchlight examination. They should do a proper occlusion of the eye, and then they have to document it. So you have a skill assessment rubric, and you also try to see how you can assess them. Now, based on that assessment, if they are really up to the mark, only then you have to put them on that work. And again, you must have a system for monitoring. How many patients are walking in? How much time do you take? So for disposing these patients. If you don't have these metrics, making sure that there are no errors, and we are able to serve them in a defined period of time, we may not be able to grow the practice. So to consolidate, so planning for the infrastructure and workforce based on your defined service standards. You have to define your manpower. You must have in place a clinical and safety protocols, and also make sure that you have systems for efficiency. And equally important is also getting the patient feedback for improvement. Now, without that feedback, we may not be able to improve. So once again, I would like to thank the chair and the ARC team for this opportunity. Thank you.
Thank you. I wanted to ask you, the systems and the processes are all wonderful, but what is your in one sentence can you say, what is that selling point which ensures that everything is happening in a very... What is your selling point which ensures that everything is happening sequentially? Is it that those review meetings which you keep having, you do, or you keep having one senior over the junior and like that? Who takes care that whole thing doesn't collapse? You have 2,000 OPD or more sitting there.
What is the clustering of, when you have 2,000 OPD, like in our case, you have to cluster them into different areas. And define the team, and define who's accountable, and you monitor. For me, for OPD, I only look at how many patients are seen within 1.5 hours. I would like to see that 90% of the patients at whatever clinic should go within that 90 minutes time. Now, if we are able to have defined that time, it may be 30 minutes. Because if you typically see ophthalmology, the interaction time is less than 45 minutes. If you put the vision, refraction, auto refraction, intraocular pressure, even BP, dilatation, a doctor to see, maybe even indirect, all of that should not take more than 45 minutes. Maybe another 30 minutes, 75 minutes is okay. But keeping any patient beyond that time is not patient friendly. So if you are able to monitor that one thing and make sure that why it is not happening. What is it? One of our hospital, they are taking up to 3 hours. Just by adding 2 refractionists and maybe 1 person for counseling, the 7 doctors were able to do the job they were doing in 3 hours, now in 1.5 hours.
Yes, exactly.
Okay. So understanding that part is very important.
Just adding to what Dr. Chitra Madam was asking, as it is commonly asked, they don't respect what you expect, they respect what you inspect.
Yeah.
So how do you try to ensure, see, the digits are just adding on for Arvind, each and every hospital every year, the zeros are just adding on for the OPDs. And with such a large volume, how do you keep the systems at checking at place? And secondly, you have shown a wonderful rubrics and this thing. So who fills that rubrics? You have a floor supervisor or a doctor or a medical officer or the HOD. Who does? Is it at the step level you try to fill the rubrics?
Yeah. So we have structured our mid-level ophthalmic personnel training in 2 years. So the first 6 months, what are the things? We start with vision. Even escorting is an art. is that we need to know exactly this is the way they have to be escorted. So escorting a old person is different from escorting a young person. Okay, so I mean escorting vision, there are certain things we make sure that it happens the first 6 months. Then every 6 months we have certain things. So on the job somebody will assess them and make sure that they are doing it. Then there is also, we call it like a formative assessment.
And it will be masked assessment.
And then at the end there is also an assessment where at least 5 patients they should be able to do it correctly. Only then they are certified to do the job.
What if they are influenced, sir?
Yeah.
What if they are influenced by their peers? What if they are influenced by their colleagues? So these basically the supervisors, what you are asking them to.
Supervisors are the people who have to do it. So supervisors, we have not a category like supervisor who takes care of the clinical flow. There's a tutor. They are supposed to be teaching them on job. So every clinic has got a tutor. It's not only the teaching, it doesn't happen in the classroom, but also happens in the clinic. Their job is to teach and train these people. So we are also getting into this process of developing rubrics, making sure that every person is, as you said, the volume has increased. The number of people whom we take every year today now has touched 1,000 people. So we cannot depend on dedicated teachers to do that. We need to have a large number of people who have to be given a system, responsibility, understanding of what they need to do.
Thank you. There's so much, we can spend the whole day with you and still we'll be nowhere. I would invite Dr. Saurabh Chaudhary, who is the medical director of the Eye Care Eye Hospital, Noida. And when I went to ask for votes, that's when I actually visited many of these hospitals, and I was so amazed at one corner of Delhi and such systems in place and so clean and so organized. And more importantly, every room when I visited the doctors, the happiness of them working there was so palpable. So how does this quiet, serious looking man keep them all together is what I need to know. And he's going to talk, of course, on inpatient and OT setup, specific planning.
Sorry. Good morning, everybody, and good to see so many people in the morning session. Before I start, I'd like to thank Arvind and Laiko, because I was in Coimbatore for a short while and I'll be going back to Madurai for some time. And all these things are possible just because I've been going there. I've worked under Dr. Narendra for 3 months in Coimbatore as well. So I had a great time there. Thank you, sirs. And I'm feeling honored to be sharing this platform with you. They've been my teachers and right. So what I am going to put across is how to set up a OT setup. So there's going to be a few nuances here. And the first is the infrastructure. And the second thing which I will lay emphasis, and which I, as an ex-NABH assessor, and I've been getting a lot of questions about, is the air conditioning standards. But what we need to understand that cataract surgeries has become one of the commonest surgeries being performed in ophthalmology. The number of patients requiring a cataract surgery are increasing over the years, and especially in the major hospitals, they exceed the capacities of these hospitals. So the surgery has become safer, and the number of procedures have increased in the ORs. What we need to see is that these patients should go out, A, satisfied, B, having good results. And how are you going to ensure that is by maintaining a few standards. Where do you get the standards from? Is from various organizations who will tell you what the standards are, and you try to follow them. Now, it is not mandatory that you follow them to the T. It is that you are getting these standards and you have to make your own standards. So there is a concept called minimal acceptable risk. So once you say, I'm ready to take that minimal acceptable risk, but there are some things which are inexcusable, because if you land up with a complication, with the endophthalmitis, with the patient going mortality, then you can land up in a lot of problems if you're not going ahead with the standards. Just as a historical preview, these used to be the operation theaters, and that's how the name came up. So the theaters were where the people were having a look at the surgeries being done under the candlelights, which have changed into these modern OTs. But to start with, what is a operation theater complex? So it's an environment of varying degrees of sterility, and that's very important. It is a complex where there are different areas of different sterilization levels, integrating the surgical as well as the anesthetic equipment, besides the staff, the surgeons, for a safe conduct for a surgery. So most of the words are very important here. Safe conduct of surgery, varying degree of sterility, surgical and anesthetic equipment, and the staff working there. So there is no standard design. So it's not that I can pick it up from a textbook and say, okay, this is the design which I want to follow. So what you have to do is just keep a few concepts in your mind, and I'll go through them in the future slides. But you have to see that you're keeping those concepts right there before you plan your OT. And as Dr. Ravindran said, you have to have a vision for the future. How many patients are you expecting in the next 3 to 5 years? So as I said, that we must conform to the basic parameters. And once we say basic parameters, that means you're taking it from the standards. And the standards can be very high, they can be low, but you have to keep the basic standards in mind. So there are 4 zones of the OT depending on the sterility. The sterile or the ultra-sterile zone, which does not need any definition. It's the area where you're operating the patients. There's a clean zone, there's a protected zone, and a disposal zone. So the outer zone is the area where the patients can come in, the patients come in, that's like the reception of the OT, and it has to maintain the cleaning standards of any hospital. The next is the clean zone. So as surgeons, as patients, they should get out of their street clothes, get into the clean zone, and that's change their shoes, no shoes going in, so that's the clean zone. The third zone is, as I said, the operating area, and the last is the disposable area, which has to have a separate, it cannot mix in. So I will talk about the mixing a little bit later. So complex should be scientifically planned. There has to be a barrier system between the zones. It should be located away from the inpatient department in the busy areas of the hospital. It is not that people can just walk in, so it has to have a controlled access. Besides that, the walls, the floors, the false ceilings, everything should have minimal joints with coving on the flooring and the walls, so that there is no accumulation of dust. The clean lights, what are available in the labs, similarly, so that there is nothing which can accumulate over the lights. So that is one thing which you have to keep in mind. So as I said, there has to be separate entry for patients and staff. And I will just try to, I've made a slight sort of a schematic sort of a thing here, which I will try to explain. So that's the OR, that's the central OR where the surgeries are happening. So let's first talk about the patients. So the patients do come into the OT, and there is the outside corridor, or as I said, the reception. From here, they continue on to the anesthesia room. So this is all in the clean part of the hospital. Then they go into the OT. Once the surgery is done, they come back out into the recovery room and then into the outside corridor. So in case we notice, there's a circle here. So there is this circle which is being formed. And once we are saying a circle, it means that you're not going back on the circle. It is only one-way directional, right? So similarly, if I talk about this surgeons getting into the OR, so that's the entry of the surgeon. They get into the changing rooms. From the changing rooms, they enter into the scrub area. After they're scrubbed, they get into the OT, perform the surgery here, and get back into the staff room. From the staff room, they can get back into the changing room and outside the complex. So again, there is a single sort of a unidirectional flow of the staff, the doctors, everybody coming in. Now, the third most important part is the instruments, the equipment, the instruments and the linen. So when we say, right, so we've done a surgery, there is dirty linen which is coming out. It cannot go into the clean areas. So there has to be a dirty disposable area where it is coming in. And from the dirty area, it goes into the cleaning area, then to the CSSD, the autoclaves, back to the sterile store and into the OR. So again, there is a third circle which is forming here. And there is minimal overlap between these 3 circles. So that's what is most important, that we are talking about 3 main circles which do not have overlap upon them. And whatever you do, you can actually think of planning the OT. As I said, there's no specific OT design, anything based on that principle. So when I did show that, I'll try to, I've just drawn out another thing here. So how to basically, no, that was a schematic sort of a thing, and I just put it in a plan like that. So the patients are coming into the pre-op. From the pre-op, they get into the OR, they get their surgery done, get back into this post-operative area and back out. And if you're talking about the doctors usually have a separate entrance. So the doctors go in through this area into the change room. From the change room, they'll go into the scrub from a side door into the OT, perform the surgery, and get back into the change room here. So there is a separate circle. We will see very little overlap. But the most important part here, and which is, I'll say, is the what you have to concentrate on, is that there's an instrument. So because the instruments are the things which get contaminated the best. So if, let's say, this is the OT where the surgery is being done, the surgery is done, then the equipment, the instruments are all contaminated, the linen is contaminated. This needs to go out into a dirty corridor. So there is a pass window through which it gets into the dirty corridor. A person takes this through the dirty corridor onto the CSSD, which has different barriers, and I'll talk about that in the next slide. But as it goes into the CSSD, there is a dirty utility, there's a clean area, and then the autoclaves. Once it comes out of the autoclaves, it gets into the sterile area, into a sterile store, where it is kept under air-cooled, in air conditioning circumstances, so that they're not contaminated, and then back into here. So again, there is a circle, there is nothing which is overlapping each other. So that's the basic premises of a operation theater. Now there are barriers in the CSSD as well. So equipment coming into the dirty area, they are examined, they are then passed through a barrier into the cleaning area, where they're cleaned by the various methods, and I'm not going into that. They're packed up, and then they go into the autoclaves or other sterilizing, maybe a ETO or whatever you have there. And then they go out into the sterile area to the sterile store. And when required, these are pushed back into the OT where the surgery is done, and they are moving. So moving back. So there is a single movement, and again, a unidirectional movement, and that's what I wanted to emphasize. So there are a few standards which are given by the NABH, and I'll be talking about those because I do get a lot of questions about that. So the paint could be, now when we talk about a modular OT, for an ophthalmological setup, a modular OT is not a must. What is a modular OT? A modular OT is a specific pre-made, prefabricated structure with a distance between the wall and the brick wall and this wall which you're creating, which is totally smooth. There are no crevices. You can keep that in mind. You can use large tiles which are vitrified, so that there is no space between the two tiles, and there is no space where dust can accumulate. So again, as I said, if there's a paint, it should be antimicrobial, antifungal paint. The OT doors have to be hermetically sealed. That's the only condition. Can be automatic, can be mechanical, can be touch-free, but that there's no standard of that in an ophthalmic OT. So ophthalmic OT comes under the general OT categories or a daycare facilities. The lights, as I said, clean room lights. So the lights are something like that, where there's nothing which can accumulate over the fixtures. There has to be a provision against the static charge. Again, that's a questionable thing. Even if you don't have it, it's not a problem for an ophthalmic OT. There has to be a separate power circuit for equipment, like the microscope and the phaco machines. But you have to keep that, otherwise it can. So when we're talking about the separate power circuit, it means that they should be on the UPS, because these are the equipment which are most important. Besides a UPS, they should have a different distribution board. So coming back to a very important part is the air conditioning. What is wrong with the window or a split AC is that these are circulating units. That means if this is the air conditioner, it is pulling in the warm air from this room. This goes into a outdoor unit where it gets cooled with the refrigerant. Could be cold water, could be anything, and then it comes back into. So these are just circulating units. Once they're circulating, there is a scope of getting a lot of bacteria in this system. And the second thing is, whenever we're talking about air conditioning, it is coming in and there is a haphazard movement of the air. So the air from the air conditioner might be going towards the floor, and then it comes up. So the dust from the floor can always go up. It has been shown that the laminar airflow systems are the best, and they do get down the infection, the microbial counts to up to 1,500 times. So that is what the studies show. Now, what is a laminar airflow? It is a non-turbulent air flowing in parallel lines from the top towards the table. From there, it is going towards the floor and getting sucked in through the small chutes at the floor level, going back into the AHU and coming back. So I'll just explain that. Besides that, the temperature, humidity, pressure, and cleanliness has to be maintained. And as I said, the vertical laminar flow ventilation was found to reduce the count of bacteria present in a typical operating theater by a factor of 15,000. And that is a very important factor. And it has been proven in the UK as well as in the US. So that's the laminar airflow. That's the filter here through which the air is coming in at a specific pressure. Once it comes in, it goes onto the OT. Because it is at a pressure, it goes down towards the floor. As it goes down towards the floor, it is sucked in by these chutes which are present here. The air from here goes back into the AHU, back into the HEPA filter, and back here. So like any other concept, this is a unidirectional flow of air. That's a typical AHU. So the air coming in is pulled out. And sorry, what I forgot about telling here is that there has to be an air exchange. So when I said that these are circulating units, that means, I'll just finish in 2 minutes. So they'll just getting the air back in and putting it back. There has to be fresh air which has to be pumped in. So that's a AHU, that's a motor. It goes through the micro-V and the filters. Then this goes on to the, so that's a typical photograph of a AHU which is mounted onto the floor, and that's the HEPA filters. This is the plenum, so it comes in through here, so it gets organized. So that's a plenum of a HEPA filter. So as I said, the general OT standards are what we require in our setups. That's a daycare center. Though it never says that in a standard that you have to have a laminar flow, it doesn't say anything of that sort. But the standards which are put across, it cannot happen without having a laminar airflow. So it does say that in a super specialty OT, you have to have a laminar flow, but the standards here are that you cannot achieve that without a laminar flow. So there are a lot of questions. Why not other ACs, and then we can achieve those standards, but it's impossible to achieve those standards. So you have to have a laminar flow. Again, a positive pressure, so that once you open the room, everything goes out with a specific air velocity. As I said, positive pressure, because like you open the door, the air should go out, nothing should come in. Again, a unidirectional sort of a thing. The temperature, the humidity has to be controlled in the OT. There has to be, the doors are hermetically sealed. There has to be these monitoring devices. How do you monitor what is happening? So you have to monitor the temperature, the time, the differential pressure, and the HEPA filter status. Now, there are others which are optional, and this does bring down the cost quite a bit if you remove the lighting controls from here. So others are the automatic substations, pass box, as I said, it is very important, the clean room standards. And thank you. Oh, sorry, I wanted to talk about the IPD. So there are no fixed guidelines again for the IPD. Most important is to maintain the hospital cleanliness standards. Again, to emphasize, in the IPD, there should be unidirectional movement, patient coming into a post-operative ward, then back into the ward, and a discharge from the ward into the OT. So that's a unidirectional flow. They should have different areas. And I'd like to end here for the paucity of time. Thank you.
Thank you very much for taking so much pains and passion to try to tell our LDB candidates how the whole system has to be. I would ask you a question from you, Dr. Narendran. Like, how can you plan on the waiting time of the inpatients? You call them all together in the morning and tell them to stay on till evening, till the surgery is done? Or do you stagger them? Is it possible? Maybe in your setup it's different, but for all the youngsters in this audience, how do they do it? And another second question which I have to ask is, if it is going to be a total camp surgery, do you prefer to do all SICS to complete it fast, and just keep the last lot for phaco, or how do you do it? Both questions.
Regarding the post-op follow-up.
No. Waiting time. Pre-op waiting time for the inpatients.
For the pre-op waiting time for the inpatients, normally we ask all the daycare patients to come early in the morning, so that we try to finish by 10:30 and send them back. Because we have the liberty of calling the inpatients at our so we do that. And regarding your second question, this is
second question was, what is the proportion in a camp of phacos and SSC?
regarding the camp patients, we always do SICS with the proper lens, but we keep few for training purposes. That's the only area where we do find.
Yes, Dr. Deepak?
I wanted to ask Dr. Saurabh.
Ah,
So his diagrams were very elegant.
Yeah.
He showed that the
Sir, you can just come here for the recording purpose.
so he wanted the patients to come in a separate room. The doctor also and the surgeon also comes and comes in a separate room. And after that, they go in a separate room. So this is a beautiful layout. The only thing is we need to have multiple doors in our operation theater. So is it how can you prevent the sanctity of the air there? Because multiple openings, and then we also have an exit for the
Pass window.
non-surgical goods.
Right.
So we have almost 4 openings in the operation theater.
Right. So two doors, one pass window, that's enough. You can have one door if the scrub station is very near, you can enter that.
So the
Now,
patient and the surgeon can enter through the same thing.
no.
it is supposed not to
Not to
enter,
do it.
Okay.
not to do it. It is not mandated. So when we're talking about this, we're trying to set up a unit for the people who are starting off here. So it is not mandated that there should be only one door. There's no standard which is saying that. But it is preferable if there's an option, you can have 2 different doors for entry of the, right? Now, once you're talking about maybe 3 openings, 4 openings, 5 openings, 6, it does not matter because there's a positive pressure in the room. The laminar flow is giving a positive pressure. Whichever opening opens up, the air is going out of that. There is nothing coming in. So as I said that there might be 6 openings, but because there is a positive pressure in the room, the air is coming in at a positive pressure, which has to be maintained at 50 pascals, which you see on your tile, the monitor tile. You open any opening and it goes out, and all these openings are hermetically sealed. So I did show that there are hermetically sealed doors. Could be mechanical, could be automatic, so that's also not mandated, but they could be flanged, they could be sliding. So these are all the standards that they have to be hermetically sealed doors, which now I think all the labs and all the pharmaceutical companies have it. So I don't think so that should be.
The only thing is the cost goes up if you make 4 sliding, at least 3 sliding doors and.
I agree. I agree. So before we
what is the minimum accepted standards like this?
Okay, so as I said, there's no there's nothing which is defining it. There's nothing which is defining it, right? So
Only the clean corridors and the dirty corridors and all those areas should be defined.
yeah, so that is the basic standards. And if I say you can always go wherever you want to, there's no end to it, right? So at this platform, when all these people are looking at setting up a OT, I did try to put the basics right here, the basics which are important.
Very important.
Otherwise, you can go on and on and on.
Yes.
So that
Yes,
and that way
yes.
you never.
Yes. No, I think,
Sir, wonderful talk.
yeah.
So when you speak about the fresh air, you spoke very well about the AHU, how it works and everything. But what about the fresh air which is coming into the corridors of the OT? Fresh air in the waiting room of the OT, because that is usually connected with the VRV, if I'm not wrong, because VRV is the variable refrigerant volume, which I think most of us have used it. And for the audience here, VRV is basically multiple indoor units with one outdoor unit, one big outdoor unit. So most of the hospitals I have seen is using the VRV technology. But how do you pump in the fresh air, or you just leave it?
So as I said, there's a AHU, and each OT, let's say you
That
have
is inside the OT, sir, but I'm
Right.
asking outside.
I'm just coming to that. So if there are 3 OTs, each OT has to have a separate AHU. So
Yes.
that's
Yes.
now, because each OT has its own microenvironment. Now, when we are talking about the fresh air coming into the OT and going out, when we are talking about a VRV, it is a circulating unit like this. This is a VRV which is working.
Exactly.
Yeah. So there is a big unit outside, and it might be supplying the 3 rooms or 3 units here. Now, once you open up the door, there is fresh air which is circulating, and this fresh air is coming out with the pressure. So it is actually going into these clean areas. These are not sterile areas. These clean areas where this fresh air coming in from inside the OT. And when the corridor door is open, it is going out because there is a passive positive pressure which is being built up there. It is not an active pressure like in the
Yes.
OR,
Yes.
but there's a passive
Passive,
pressure which is being built up in the corridors. So whenever a door opens, the air goes out. So a positive pressure here, a passive positive pressure here, the same air which is coming in here escapes outside. So
I got your point, sir.
We have
But
to
there is
move
new
on.
technology which is coming in.
Yeah, so you
where,
can- so,
where they
again-
inlet the fresh air also
So
coming in.
we've got that. There is VRVs with, but the cost goes up quite a bit, and it's, as I said, it's not mandatory. So mandatory. So I was talking about the basic levels. Otherwise, as I said, it can go through the roof. You can always. So there is fresh air which can be mandated to be put through the VRVs, and it's another unit which you have to put there. But the cost goes up quite a bit. So we've got the VRVs in our basements, which also push in fresh air because there was a smell there. So we've got that done. But as I said, that it's endless. That's not this time.
I think
Thank
we're
you, sir.
really
Thank
running out of time. So thank you very much for everybody's contribution. We go on to our third speaker, Dr. Narendran, who needs no introduction, is the Chief Medical Officer of the Arvind Eye Care Systems based at Coimbatore. And an amazing setup they have, and they are really expanding further, doubling up the space. And that tells us how amazingly they manage the volumes. And he would be talking on outreach program planning and execution. It's just not what they do inside, it's what they do outside, which keeps them at a different level from all of us.
At the outset, I would like to thank Dr. Chitra and members of the ARC for giving me an opportunity to be here today. As an eye care provider, it is important. We all know that what we should do, but it's also important that we should know why we should do. For that, we should have an understanding of the backlog, the gender inequality, the urban versus rural ratio, and also the aging population. Coming to the backlog, it's heartening to see that both blindness and visual impairment is declining over the years. But it's very important that one should understand that the absolute number of people with either blindness or visual impairment is nearly 10.81 crores. Coming to the population, the urban versus rural, we see that around 898 million are still in the rural areas. And these are the people we should cater really through outreach programs. And as far as aging is concerned, we all see that the aging population in India is on the rise. Right now, it's around 267 million of people who are above the age of 50. As far as gender inequality is concerned, we have seen that around 25% more females have either bilateral or unilateral cataracts. And resources, we all know that in India, we have around one ophthalmologist per 70,000 population. And when we compare it with other countries, it is very less. And most of these ophthalmologists are concentrated in the urban areas. So we should need a good planning system for outreach programs, which includes improving our goal setting process. We should also plan and utilize our resources optimally. And it's also important that we reach the unreached, in the sense that we cater to areas where there is an absolute need, where there are no ophthalmologists around. And also, what we should keep in mind the productivity, because any program should be cost effective, and also monitor and evaluate our outreach programs systematically. And lastly, we should continuously improve our patient care services. As far as improving goal setting process, we can at Aravind have an annual planning meeting as far as outreach program is concerned, wherein we set a target for that next year. This is based on the trend in the annual growth rate, productivity trend, analysis like the outpatients and inpatients per camp, lessons learned through previous experience, and also potential that's available weeks per year for the camps, because one should also take into account the festivals, the other local programs. And it's important that one should plan and utilize the resources optimally. Once the goal is set for a year, then we should design the service delivery system, whether we are going to how many cataract camps, or cataract with refractive errors, or comprehensive camps. It's better now to have comprehensive eye care services, because we can tackle both preventable as well as curable blindness. And also we should plan our resources like manpower, the infrastructure and supply chain. We should also strengthen the planning process, thereby helping to achieve the goal, to utilize the resources optimally. This is how we potentially staff for the outreach program. For every 150 outpatients, we expect around 40 cataracts, 40 glasses, and we send in a team of 6 staffs. The volunteers for registration are usually sourced from the local area, from the local organizers. For a camp which has we expect an outpatient of 150, we send in one doctor, one ophthalmic nurse, one optometrist, one counselor, one optician, and then one organizer who takes care of the overall coordination. Like I told you, we should reach the unreached. Normally, we have a service area wherein we divide each of the Aravind. We have a service area wherein we cater to around 10 districts from each hospital. We divide the district into taluks, blocks, and also villages. There's a potential of around 300 villages in each block. So we cater to at least see to it that 40 villages are covered through our outreach program. We all, like I already told you, we have an annual planning meeting wherein we set in an annual target. Then we break it into monthly planning, and also we conduct weekly meetings so that we plan for that week. And we also develop appropriate strategies so that we achieve the goal. And effective execution of strategies will increase the productivity per camp. It's very important that it should be cost effective on the long run. The effective planning process and execution, mainly we should focus on productivity. For example, the cost for which we spend for a camp is mostly fixed cost, like publicity, HR, and others. So the productivity is directly influencing the cost effectiveness of the camp, which we normally do not usually calculate or analyze. For example, normally we spend around 15,000 for pre-camp preparation, awareness, publicity, and campsite logistics, and another 10,000 for medical team, the human resources, transport of the team, outpatient services, and hospitality. So if the camps are really productive, like if you see 60, if you get 60 inpatients, the cost per inpatient works out to around 417 rupees. Whereas in the same camp, if you get around 20 inpatients, then the cost per IP rises to 1,250 rupees. So the as productivity increases, this brings the unit cost down, and we should keep this in mind. And also we should systematically monitor and evaluate all the camps every week. This is mainly a managerial function. We collect a lot of data, but it's very important that you should analyze them systematically. And that's a strategic way to ensure efficient achievement of the outcomes. And we should judge the value of each outreach program. As far as execution is concerned, we should focus on alignment of resources, design the system to complete the service loop, standardize all the protocols, and monitor the output and outcome consistently. Outreach is not just a responsibility of a small outreach team, but everyone in the organization from top to bottom and from bottom to top should participate in it. This is how maybe the video is not working. Normally, this is the outflow of any outreach program. We start with the registration, then after that,
It's not working. You've tried. You leave it.
Then we have the visual acuity measurement. then the preliminary examination by doctors, and based on whether they need a refraction or if they have if we send them for refraction, and if they are ideal candidates for cataract, then we send them for intraocular pressure measurement and duct, and then the final examination by doctors. But it's also very important that now we do an intraocular pressure measurement for everyone above the age of 40. And after the final examination, then we, depending on the nature, we advise medication or spectacles, or we refer them to the specialty wherein they go for the counseling and they are asked to come to the base hospital services. If they are advised cataract, then they undergo a blood pressure and blood glucose test. And then we also take a systemic history, counseling, and admission. And these patients are transported to the hospital on the same day and surgery done. And then we go for a 1-month follow-up to the campsite. This is how it happens. Like we do a on-site transport, pre-operative investigations. Once the patient come into the hospital, then the surgery is done. Then they are discharged with post-operative medication, and the follow-up is done after 1 month at the campsite. Last year, we have done around in Coimbatore, we have done around 360 camps. We're screening a total of around 76,700 patients, and we got an average inpatient of 81. Apart from these comprehensive camps, we also have some specialty camps like diabetic retinopathy screening camps, which are done regularly. For want of time, I'll just go through this. And then this is the number of camps which we did last year. And then we also conduct workplace camps. For example, we identify industries which have a sizable number of workers above the age of 40, and then we do these camps so that they need a presbyopic glasses, and studies have found out that the productivity of that worker has gone up many times after the camps. These are the school screening camps where we train the teachers on how to check for refractive errors, and then they go back to the school. They they examine the children, identify children who need examination by an optometrist or an ophthalmologist, and then the team goes to the school and screens them. And this is the recent one wherein we started screening also for retinopathy of prematurity, which we started in the year 2015, wherein we had screened close to 38,000 babies. And these babies, we saw that around 7% of them needed some form of treatment. Also, we should also keep in mind that we should continuously, there should be continuous improvement in patient care services in the form of social auditing, internal auditing, and clinical auditing. So to conclude, outreach programs is for any outreach program, we should have an exclusive team with clear role clarity and accountability. It's a top to bottom initiative, and they need continuous support. But when it comes to action, it is a bottom to top plan. And we should have a systematic way of goal setting and standard protocols and robust system to monitor the performance. Thank you.
Thank you, sir. Thank you very much for that wonderful talk. One question, last question to Kalpana, madam. Sir has nicely explained about, okay, going in a camp, one doctor for 150 patients, one opto for 60 refractions, one nurse for 50 BP. I have also seen that you have a prediction.
There's so much.
That you predict that how much patients might turn up for that camp. Otherwise, I send a full team and some other hospital comes and does the camp and goes off, and then low turnout. So how do you predict the number of patients attending these camps, so that the optimal allocation of the human resources will happen?
Usually the camp organizer, he will go and do the work because he knows the potential of that area.
माइक दे दीजिए प्लीज माइक कैन एनीबडी हेल्प
Mike, Mike.
माइक
It's better now. I think I'm
Yeah.
audible. No, ideally what they do is this every camp, no, the camp organizer goes and fixes the camp. He will know the potential of that camp. So they will see the population. The population will be there, the CSR rate in that area, the sponsor. Suppose if the camp has been happening for 20 years, then we know how many patients will come in. So that is how we plan. And the previous history. So
They would also
based on
pre-register,
that-
no? Patients would be pre-registering
some of
for
them
the.
we used to pre-register, but now I mean, if it pre-registered, it's always gives a good idea. But otherwise, sometimes there are a lot of walk-ins directly also. So that is how we plan. So it will be the organizer who will give the idea. So been doing it for years.
I had seen in one of your meetings, sir, you give a prediction that 60%, 70%
yes.
of these will turn up. So that's a wonderful thing. So that you, the very good human resource allocation will
But
happen.
we also very rarely now, with all this experience, we don't have surprises. We because we know already, but very rarely we do get sometimes unexpected crowd. We always manage.
One last question. I know we are run off the time. Like, your vision centers are a brilliant concept by even which you draw patients. That is also part of your outreach program. So, for a particular practice to grow, what do you believe that a vision center is critical? It's only for big practices like yours, or all practices a vision center? And what is the ratio of one hospital to vision center?
Actually, the bigger centers, like, we in Coimbatore, we have around 13 vision centers attached to us. So, I mean, getting good manpower is one thing. The other thing is, even for smaller practices, having a vision center is not a bad idea. Because if you have a proper referral network system from the vision center to your clinic, definitely. And I think, like in Northeast, I was talking to a particular doctor. It is all in the mountain areas, so not everybody will access. So vision centers, even for a smaller hospital, might be a good idea, but you should have the adequate manpower and a proper referral networking system.
Thank you.